Welcome everyone to the Buncke Clinic Virtual Visiting Professor Series. On behalf of my partners, Drs. Greg Buncke, Rudy Buntic, Andrew Watt, and Walter Lin, and myself, I'd like to welcome you to this morning's talk. We have the distinct honor and privilege to introduce one of the giants in our field, Dr. Bo Pomahac from the Brigham and Women's Hospital in Boston. Dr. Pomahac really needs no introduction. But I have a couple of slides just kind of summarizing what he's doing nowadays. He currently is the Roberta and Stephen Weiner Distinguished Chair in Surgery at the Brigham. He's also director of the Plastic Surgery Transplantation Program, and this is what he'll be discussing today. He's also professor of surgery at the Harvard Medical School. When I did a search for Dr. Pomahac, the second hit was a Wikipedia entry. And when you have a Wikipedia entry, you know that you're a pretty big deal because most of us don't have one. So I think we'll see very shortly why that is, because he's done some incredibly impressive work. Dr. Pomahac joined the Brigham in 2004 and subsequently became the medical director of the burn unit of the burn center at the Brigham and Women's Hospital in 2009. And he remained in that position until 2017. He in 2017 also became the Roberta Stephen Weiner Distinguished Chair in Surgery at the Brigham, and he also established the Plastic Surgery Transplantation Program at the Brigham, which has gone on to become really one of the world's leading centers in not only face, but vascularized composite allotransplantation in general, because they've also done hands, and I'm sure he'll talk about that today. Bo, thank you so much again for joining us today. It's really an honor and privilege to have you, and we're delighted to add this very important topic to our Buncke Clinic library. Thank you so much again.
Oh, it's a pleasure to be invited, and thank you for having me. I am gonna talk today actually mostly about our experience in face transplant. Let's see, can you see my slides?
Yes, we can see it.
Perfect. So, you know, I thought it's getting not quite, but pretty close to 2 decades of face transplant, and so I wanted to share with you some of my personal views on things. And in a big picture, I was sort of late arrival to this endeavor, and there were pioneers, as you are probably well aware of, before me. In particular, Max du Bernard, Bernard de Vachel, Sylvie Testelin, and Benoit Langelet, the French Amiens group that really pioneered the facial allotransplantation. There was also the US Maria Simonov, and back to France, Laurent Lantieri, and those groups. So I frankly became an attending 2004 at the brink of this becoming sort of a new field. And I quickly realized after some of my difficulties and struggles in facial reconstruction that there may be future in this endeavor. So I don't really have any disclosures financially, but I do want to give credit to my 2 greatest mentors, Dr. Erickson and Prebaz. I would say Elof is sort of my American father, and since I arrived to the States, he has been really an incredibly important career mentor and leader that I admire to date. Julian has been sort of a person that inspired me in facial reconstruction, and he's really why I chose plastic surgery, probably. And I would also say that most of the things I know I've learned from him. So these people were not only greatest mentors, but they were also people that made our program feasible here in Boston, because without their support and without the backup of someone senior like Julian, you know, to put it in perspective, I was 38 when we did the first face transplant. So you want to have someone like Julian around in case there are some sort of issues. So we all know the difficulties dealing with central facial reconstruction. And, you know, this is just the one slide showing the enigma of plastic surgery, the nasal reconstruction. And sometimes we can hit near home runs or pretty good results, but all of those cases are staged, require multiple revisions. They either, look good or patients can't breathe through them, or the other way around. So they are incredibly challenging, especially in the setting of radiation and lack of tissues. And of course, the larger the defects, the more complex these cases are. And ultimately, those cases turn into rather wound closure than true reconstruction. Because it's impressive if you take a skull and look at the pieces like maxilla, mandible, or they're tiny three-dimensional bones, but they're incredibly complex in contour and shape and attachment and so forth, integration, and it's so hard to replace them with anything else. And any layer you go more superficial to the bone, it kind of adds to the complexity, moving lips, breathing nose, cheeks, eyelids, and so forth. So inspired by the French and understanding how tough it was to really do some of these central facial reconstructions. And for some reason, actually, I saw more than ever during the years 2004 and 5. I started thinking of creating the program, and actually it took from 2005 a few years to get to the first approved IRB in 2008. The first IRB was actually intended to include only patients that have had prior kidney or other organ transplant, ideally kidney, and it was both because I was still nervous and concerned about the impact of immune suppression, and also because of the payer's perspective or payment for these operations. I knew that we could write off the surgeries, but there were no funds to maintain lifelong immune suppression for these patients, and so the choice was to pick immune suppressed patients. Also, it created a little bit kind of, I would say, a lower bar to convince all the interested parties, like the chair of IRB, the president of the organ bank, and my colleagues, because it wasn't seen as threatening, and the biggest challenge of the benefit of transplant versus lifelong immune suppression was suddenly out of question. And interestingly, after we got the first protocol approved, it was incredibly easy, even though it's a giant leap from non-immune suppressed to immune suppressed patients to start with recipients. It was remarkably easy to broaden the protocol to any patient. I was actually inspired by a patient that I saw had a nasal and upper lip basal cell cancer kidney transplant patient who required extensive resection. And when I told her about the stages and what we would need to do, she essentially said, I'm not doing it. I would rather die. Just radiate me. I'm going to die with my cancer. I'm not going through this. And so that's when I thought there may be patients like that in the population. Our first transplant was done in, actually it was April 2009. And we since have performed 8 additional, so total 9 transplants, as well as 4 bilateral upper extremity transplantations. One of them failed shortly after the transplant due to sepsis and general sort of vessel vasoconstriction. That was a patient that had transplanted face as well as bilateral hands, and the face fortunately survived, and the patient is doing well today. We also have started to expand to very controversial lower extremity transplant and uterus transplant, which is currently led by Dr. Tullius, our chief of transplant. So it's important to look back because so many things have changed over the years. Back in 2008, we were dealing with donor consents. We were dealing with timing of recovery. We wanted to go first because the dissection we knew was going to be tedious. We knew that ischemia time ideally would be under 4 hours, and all of our faces and hands were under 4 hours, just to make sure that, just like hearts, you get 4-hour window before the muscle damage occurs. So we wanted to make sure that the muscle is not damaged in the face or in the limbs by the long ischemia, excessively long ischemia times, and that required getting everyone on board. I remember being slotted to talk to all the organ transplant consortia groups, which meet once every 3 months. So just going and presenting the change that we would start, we were ready to stop if there is some sort of excessive bleeding, We were going to get a control of the carotid so that we control things. We didn't know how the osteotomies may bleed, how it may stop bleeding or not stop bleeding. So all these things had to be discussed. Everybody had to be on board. Of course, the lung guys were worried about us doing tracheostomies, so we assured them we'll not do it, and so forth. So a lot of negotiations, but ultimately that resulted in the support of the regional organ bank at that time. We also needed to get hospital support, and from their standpoint, it was two issues. One, obviously, that we have a team that can do it, that it wouldn't be international disaster, and as it turned out, our very first transplant was part of the Boston Med series, so literally we had no control over what they tape and how they splice it and how they ultimately present it. And it's still, you could watch it on YouTube if you're interested. The episode 8 turned out pretty well. And then finally, you know, at that time, hospital was doing quite well financially, and they were willing to write off the cost of the operation, even though I've got several no's before I got finally yes. The IRB I've already talked about, and then the other operational issues were sort of how do you build a team? How do we make sure that we really utilize the expertise of all the people that are ready for the expected, unexpected. You know, if you do something for the first time, so complex, there certainly will be things that you thought you have thought through everything, but there certainly will be some unexpected things. And I'll mention some of them, as well as post-operative complications and so forth. Now, if you fast forward 12 years later, we have made a huge progress internationally. And these are all different patients from all over the world. I didn't want to show just ours on the right side, at least not for now. But HRSA designated VCA as organs back in 2014, and UNOS started to manage VCA donations. So suddenly it became an entire United States effort that's integrated into any organ donation. As a matter of fact, we're now in the process of implementing it, the donation of VCA into UNET, which is a network where all the organ offers, acceptance, and forms are involved and stored. So, you know, there's a lot of logistical things that go into managing donors for new donation, like the limbs or faces or uterus or abdominal wall. We have also, as a field, moved from enormous grant support, primarily by Department of Defense, to a point where the grant support is drying up, and the DoD is telling us, well, we have done our share to support and prove the concept. Now you got to push the third-party payers to start paying for these things. And in order to do that, they want to understand from the community that this is considered standard of care, something that we're still struggling with. But I think personally that for FACE, it should have a place as a standard of care because the alternatives are so miserable. The IRBs, some centers are now starting without any IRBs even sort of created for performing the transplants. For example, Samir Mardini and Mayo has a lot of IRBs or different IRBs for outcomes tracking, but not for operation itself. And that's a good first step where we pretty much ground that we no longer need this. This is becoming an operation that can be performed under standard conditions, not as an investigational operation. And we have also learned that we are able to do the surgery safely. There has been no patient that would not survive the operation in the US. And now we're moving to the next phase in the future where we cannot have one team start the operation, do 6-hour recovery, travel time, and then 12, 15, 20-hour transplantation all at once. But we'll probably be gradually moving, and especially in limbs, I could see that happening next week, where the local team would recover limbs and the recipient team would actually transplant them. So there will be some degree of division of work and labor, and ultimately will become more efficient and less tired by the end of the operation. And that's, again, down the line. For limbs possible probably now, for faces probably a little tricky at this point. We have also made a lot of technical advances from the very beginning, both in detection of which vessels are really necessary. for support of the allograft of various combinations, whether it's full phase including scalp, phase including bone, upper lower jaw, and so forth. There's been enormous progress in management of the bone and virtual planning of the osteotomies. And I have to give credit to Dr. Rodriguez, Ed Rodriguez and at NYU, Patrick Glasses in Helsinki, and Samir Mardini. Those are all guys that have really identified that being a great option. And we have since followed for our last one before last transplant with the cutting guides, and it saves enormous amount of time and increases precision, as you all probably know. We have learned outcomes of the motor and sensory nerves, and we're doing more in that research even now, using software that can detect emotions and grade the degree of movements. We're now in the process of developing a consortium of international teams, including many in the US, where we would track, compare the outcomes and so forth, grade some sort of outcomes guidelines. We have figured out a lot of mucosal and lining issues, which always are tricky. You always think you have enough, and then you end up being short. There have been fistulas in the palate. There have been all kinds of problems we dealt with. Same thing with the glands. There are some glands that are just not safe to remove during the transplant recovery, like submandibular glands, and we have suffered from complications related to sial seals and leakage. And finally, there has been a lot of progress in immune suppression management, so the patients actually do quite reasonably well. So in terms of the vascular design, and again, going back to the early 2000s, there was a lot of debate whether facial and superficial temporal vessels would be required to carry the allograft of the full face. And many teams actually performed their first transplants, including both of these vessels, just out of fear that you could develop peripheral necrosis of the face. The problem with that is that you need to include parotid gland, because it's very difficult to dissect and tedious and time-consuming to dissect the superficial temporal vessels of the parotid. And that way, either the recipient ended up being too bulky when the parotids were just stacked on each other, the recipient and donor ones, or you ended up needing to perform superficial parotidectomy on the recipient. And that could have been a problem because you have removed large functional glands, added additional morbidity. But at the same time, a lot of these patients don't have submandibular glands or sublingual glands, so you could potentially create problems related to xerostomia. And you know, our thought was from the beginning with Julian was that, you know, we do facelifts, we do aesthetic surgery. We know that the periphery of the face lives primarily off the facial vessels. So our sort of hypothesis was that the facial vessels should be adequate to carry the entire full face transplant. And it turns out that you can go all the way back to the parietal region and it still survives just fine. It's probably just the occipital region where Ed Rodriguez has been using occipital vessels as well. And we published that back in 2012. And also later on, due to one of the technical issues, we actually had a clipped facial vessel when we thought it was just bleeding of branch, where it wraps around submandibular glands. So we sort of, rather than trying to explore and try to fix it, we just revascularized the face and found out that one vessel is adequate, one artery to be specific is adequate for full face flow. So arterial inflow is not as big of a problem. We now have long-term follow-up of that patient. And here's the Fisher Sebastian published the early result, but this patient is now 5-6 years after transplant doing just fine. But it appears that you do want to have bilateral venous outflow. The facial skeleton I've alluded to a little bit. You know, there are challenges that we cannot fix by any sort of degree of computer simulation, simply because in a patient like this one, this is our first patient, you can see that you will always end up with a hybrid of donor upper jaw and recipient lower jaw. And you can see on the left side, the missing maxilla, but the existing mandible of the recipient. On the right side is the post-operative follow-up on the upper panel, and the lower panel is our patient number 3, similar scenario. So you have really a hybrid occlusion. You have maxilla from a donor, mandible from recipient, it doesn't really ever come perfectly together. Nonetheless, with dental rehabilitation, with implants, we've been able to achieve functional occlusion, and ultimately the cutting guides are a way to do it if you have both upper and lower jaw recipient. And this is a example of what we did for our patient number 8. So first, sort of identify the amount of bone that needs to be removed, then overlaid the donor, figured out the bone of the donor. And I just want to point out a couple of things. First of all, the patients that have had gunshot, I don't know if you can see my cursor, but the mandible fragments are fairly displaced. They're malrotated, and there's enormous atrophy of the bone. And similarly, because there's no load in the maxilla, if you overlay a healthy donor, suddenly you see the mismatch on the right figure where the maxilla is so much thicker and the mandible is so much thicker than any of the bones in the face. And that has caused some issues, but nonetheless, the computer simulation has been incredibly helpful in these scenarios. And ultimately, the companies are absolutely amazing. We work with Dupuy Synthes. They're able to turn it around in 24 hours, and we get our cutting guides to recover the donor, which has been tremendous. So that has worked well for us. The glands, I've alluded to the parotid and the issues with including superficial temporal vessel. In terms of the submandibular vessels, again, the facial artery wraps around it, and then it goes over anterior surface of the mandible. So it's kind of a tricky and tenuous relationship between those. Plus, you have some facial nerve branches. So we have started, after the initial problems, Botoxing them. And this is an example of a patient who developed sialocele, as you can see on the right panel, with the fluid underneath the chin. Ultimately ended up being infected, probably from contamination of yeast, and the patient needed to be treated. It all turned out fine in the end, but we saw it subsequently in another patient and decided routinely not only put drains in the neck, but also Botox heavily the donor gland so it doesn't occur. And this is kind of a cool picture. You see two sets of submandibular glands next to each other, something that you know, the radiologists are a little confused until you tell them that this is a transplant. And this is patient number 6 who had a sialocele from parotid. So we had trouble finding one of the branches of the lower lip, sort of a lower division of the facial nerve. So we dug into the parotid quite a bit, his own parotid, and ultimately he ended up leaking and developing sialocele. So again, if there is a case like that, we even Botox the recipient gland, knowing that it will ultimately come back. The motor and sensory nerves were also very controversial, and to some extent, I would say they're still not completely resolved in terms of what is the right thing to do. There are still teams that believe that coaptation at the main trunk is the way to go, and maybe anecdotally, just looking some of the results, they may have more robust contraction of all the facial muscles, but they have more synkinesis, just like you would expect from the facial nerve injury cases that you have probably seen. We have always believed that targeted re-innervation, going to individual branches, would be the way to go so that you avoid the synkinesis. And we started by literally just, including cutting them at the periphery, medially to the parotid gland at the exit. What we have learned, though, is that in a couple of cases, we had to use a nerve grafts because simply due to the swelling, the donor and recipient didn't match up well. And so in the future, or now, what we currently do is we dissect back. We've identified the peripheral facial branches, dissected almost to the common upper and lower divisions, whatever there is, and then we have all the flexibility to deal with the nerve whichever way we can. But in general, we still connect at the level of the branches. Here is a dissection of partial face and how we would look. Elevation, this was practicing for our first patient in Belgium, where the first French group had their kind of home base. They have phenomenal anatomic facility that's run by Benoit Langelet, who was a critical member of the first French transplant team. And once you sort of make the incisions, identify the facial nerve branches, you see it magnified on the right side, identify the parotid duct. These are divided and flipped sort of medially. And then you can identify sensory nerves coming from above, both supra and infraorbital nerves and mental nerves and buccal nerves. So these were the ones that we include and connect to every single recipient, unless the damage of the recipient is so large that there are simply no recipient nerves. But I do believe with time we have proven that the sensory re-innervation and outcomes are better if you can co-opt the sensory nerves. The patients do develop some sensation even without cooptation, but it's never as robust and it's more unpredictable. So we always kind of going from top to bottom, always look for supraorbital or supratrochlear, infraorbital, buccal, and mental nerves. That's what I've just said. Cooptation, it leads to better outcomes. We track these outcomes longitudinally over years, both in hot-cold sensation as well as monofilament testing and two-point discrimination, and develop sort of heat maps how it recovers, and over time can see the results. And we have published all of these results. Most recently, the 5-year outcomes in New England Journal of Medicine, I think it was last May, where it summarizes the sensory return. Even though, you know, the patients keep telling us that the sensation continues to improve, there appears to be a little bit of a plateau, or the curve is relatively flat after a year. But many of them tell me that their forehead feels like their normal forehead, not when they had skin grafts or the injury, but like literally normal forehead before the injury altogether. So as we all know, the sensation should continue to get better over time. So going through our patients, this is kind of a fancy way of creating a checklist of which structures to include for which anatomical defect. And we didn't have these nice drawings at the time, but we sort of had a mental list of what do we need to connect. And many of those patients are well known and has been presented many times, but I'll just briefly mention high voltage injury, debridement. At this point, he already has some grafts on the periphery of the defect. The actual defect was considerably larger. One thing I didn't realize back then was that the lower lip was damaged significantly. We thought there was a decent amount, but ultimately ended up being little, kind of essentially atrophic or contracted. So we probably retrospectively should have transplanted the lower lip as well. But our fundamental cardinal rule has always been do no harm. So we want to make sure that if the patient fails, if the transplant fails, we do have backup options. And then we always depict what do we include. So the yellow are facial nerve branches and the orange are sensory. So infraorbital and buccal for this patient. And of course, facial artery bilaterally and whatever retromandibular vein, whatever you can get for outlet. That's the patient about 6.5 years post-op. I'll show you the latest follow-ups a bit later. There are definitely chronic changes. You can see over time, the allograft became a little bit paler. The scar kind of stood out a little bit, but his sort of animation, motion, and so forth really was fantastic till the end of his life. He just recently died of unrelated causes to the transplant, and I'll talk about that in a later stage. Our patient number 2, total loss of all soft tissues, unfortunately lost the left eye during the accident and the right eye completely blind. He had no parotid on the left side, so that's the only patient where we did transplant parotid on the left just to improve symmetry. All the facial nerve branches, all the sensory nerve branches, although we couldn't find infraorbital nerve and supraorbital nerve on the left side of the recipient. Here is how he looked 5 years post-op. Patient number 3, extensive burn, loss of lip, nose, but he had a lot of functional facial musculature, so we specifically connected branches to the upper and lower lip and all the sensory nerves which were found. He has probably the best aesthetic outcome of all patients. Before he had lateral arm flap for reconstruction of the lower lip and some of the neck, which was removed during the transplant surgery. He's now 8.5 years after transplant. Patient number 4, mauled by chimpanzee, extensive defect, also blind, unfortunately, lost both of her eyes during the attack, required fairly extensive soft tissue, all of the facial nerve branches, all of the sensory nerves, maxilla. That's her relatively recently. She lives in Connecticut, so we can see her quite frequently. The other patients don't come as often anymore because the funding has dried up and they can't afford to travel, but they're under care of local teams that we support as much as we can. Recipient number 5, immunologically most complex, burn patient, heavily sensitized, difficult match, developed severe reaction or antibody-mediated rejection, which we were able to control, but pretty much annually had major rejections that required essentially induction immune suppression, the strongest NTT lymphocyte induction management. And so she ultimately progressed to probably most severe form of chronic rejection we have seen today. Nonetheless, at the time of transplant, horrible contracture of the neck, severe pain, required full face all the way down to the collarbones, a lot more facial nerve branches on the left side, which was scarred and didn't move much, sensory branches everywhere, regained good function after the transplant, but I'll talk about her in a moment. She ultimately developed chronic rejection and is actually relisted for transplant now. But her transplanted eyelids, even though they didn't function perfectly, have saved her artificial cornea, and she was able to get 7 more years of vision. She's now losing some of the sight, but still is able to navigate in space and has some residual vision. The patients number 6, 7, and 8 are similar scenarios. Gunshot, self-inflicted wounds, all of them psychologically very stable after many years on no medications. All of them required upper and lower jaw, and we included everything that we could in terms of sensory and motor branches. A lot of them did not have infraorbital nerves, or some of them did not have them, but nonetheless have all gained functional occlusion and speech. None of the patients is drooling. There is only one patient that we're struggling with getting him off tube feeds. He just, on top of the upper and lower jaw, lost a little bit of tongue and doesn't have much appetite, so he prefers the tube feeds. Patient number 7, similar scenario, upper and lower jaw. Even though these transplants look actually a little smaller in volume or bulk, they are probably the hardest ones because the management of the bone and the depth of inset is so much, and the mismatch of the bone and all these challenges, it really is the tougher of all the transplants than just the full face soft tissue only. That's him 4 years post-op, still has a little bit of telecanthus due to the injury, original injury, but overall doing very well. And this is the gentleman that a couple of issues. He's the one who we have not been convinced to take off tube feeds, but also what we didn't know was that his right zygoma had malunion at the arch. And so when we use the computer guides, it fitted perfectly on the left, but on the right side, the bone just displaced slightly. And I just did his revisions a couple of months ago, but he hasn't been able to come for follow-up, so I don't have a follow-up picture, but we've been able to fix that with osteotomies and rotating that zygoma and improving the medial canthus region. And finally, last patient, full face burn with loss of lips and lower part of the nose, and that's him 3 months. He's about 9 months post-op now, but due to the COVID, hasn't been able to come for the usual follow-ups. So let's go through some of the successes and failures. Of course, we're incredibly happy to see the social reintegration. Our first patient was able to come to his daughter graduation from college, ultimately walk her down her aisle when she got married, became grandfather, again, socially reintegrated in his family. Our second patient got married. A lot of the patients got jobs back and things that are fantastic. And overall, there's a trend, even though in small numbers, it's tough to measure the quality of life because on one hand, you have that incredible benefit of looking more normal, functioning more normal, but the downside of the immune suppression, so that weighs on the quality of life negatively, and it's a balance that often is hard to track due to the imperfect surveys that we have. But certainly there is a trend towards improved quality of life. As I've mentioned, many of them return to work. They get all oral competence. No one's drooling. They have near normal sensation. All of the patients have been decannulated, and except of one, all the feeding tubes are removed. Of course, that's not our, God's work, but its ability to smell returns because of the scar and is released, and the airway opens up, so the air gets to the ethmoid region, and we have been able to enhance the protection of eyesight. And some of our hand transplant patients are able to return some of their hobbies, like playing guitar or even piano, even though obviously it's not a Boston Symphony performance, but they can enjoy their function. So surgical complications, we have sort of seen it all, whether it's bleeding, thrombosis, infections, fluid collections, dehiscence, fistulas. This is an example of our transplant number 8, who unfortunately had a major thrombosis of the vein. We put him on a heparin, then he bled, then so much swelling, the vein became too short. We had to put a vein graft and ultimately solve the problems, but a lot of issues perioperatively. We have had obviously the early surgical infections in immunosuppressed patients. It's a lot easier with contamination of the donor that have been in the ICU for a while. It's a lot easier to obtain some of these or get some of these nosocomial infections early on. We have talked about the fluid collections. We have had dehiscence in the mouth when patient threw up after starting tube feeds about 4 or 5 days post-transplant. We have seen 3 fistulas at the hard soft palate junction, which all of them were fixed, but required one of them a couple of reoperations, including robot, because we just couldn't get there to suture so deep in the mouth without seeing better. So robotic closure ultimately fixed it. We have seen rejections, both acute and I would say on average, the patients all have about a rejection a year, maybe a little less than that. And some of them just need a enhanced maintenance immunosuppression or increase of dosages. Some of them require more aggressive treatment. This is Carmen, the patient that I've mentioned, immunologically most complex. That's actually how she looked in March last year, 6 years after transplant. And then she shows up in July, so about, I don't know, 3 months later, and says, I'm feeling some weird swelling in my face, and I'm developing these blisters. So we had her come biopsy. The blisters were actually full thickness necrosis. These wounds ultimately ended up with topical care healing completely, but now she has developed severe contractures of the face. Her pain has reoccurred again. She's again on narcotics to manage one of the reasons why she went for transplant, and simply the transplant's failing. And it's humbling to see, because these patients, and we all would love to see them thrive for the rest of their lives, but the reality is, half-time of lungs and hearts is about 4 or 5 years, and half-time of kidneys about 10, 12 years. So we probably are going to be in the category of maybe 10 years when the transplants will start to have trouble. That's been the case of the first French transplant patient as well. And here's the publication on that report. Although we don't see the vascular changes that they did, there are 2 mechanisms that appear to lead to chronic rejection. The French guys saw similar outcomes, maybe slightly worse. Ultimately, that patient needed conventional reconstruction with radial forearm flap to close the wounds of her lips, but later died of lung cancer, which honestly, talking to experts in immunology and transplant medicine, that's not really the type of cancer that you would see increased incidence with immune suppression. So probably unrelated. She was all-life smoker. And finally, our first patient died 10 years after transplant. These are his original pictures at the time of injury, debridement, ALT for separation of the nasal oral cavity. He unfortunately had untreated Hep C for many, many decades prior to him being treated with his high voltage injury. And we treated him at that time with the old medications, the interferon gamma and ribavirin, which had some success. And he actually lost, he had 0 titer at the time of transplantation, but then his Hep C recurred, and he was treated with the novel sofosbuvir, velpatasvir, ribavirin, and voxiloprevir, all the new drugs for Hep C. He had the phenotype or genotype of the virus that unfortunately is falling into that 1% of non-responders, and ended up recurring yet again Hep C, and ultimately was diagnosed about 70 months after transplant with hepatocellular cancer, underwent a series of ablations, more treatment, but ultimately ended up just failing his liver, which I'll show you in a moment. Interestingly, over the 10 years, his creatinine and kidney function remained pretty stable. The tail of the rise is really just the very, very final months of his life. But when you can see, this is one of the big concerns in transplant patients long term. The kidneys do get hit from calcineurin inhibitors, the tacrolimus that they need. And so you see even here there is a trend for increase in creatinine function, creatinine level, and decreased function. But he ended up actually doing well from that standpoint overall. This is him 10 years after the transplant. Again, you see the transition, 5 years, looks really natural, blends in well. 10 years, considerably paler, some telangiectasias. It appears that some of the hair was falling out or was not as dense. Just some changes that we're still trying to characterize, to be honest. And this is post-mortem. Family was fortunately very generous, so we could take a look at the donor artery, which had perfectly normal thickness and no thickening of the media or intima. Maxilla looked like perfectly healthy, normal bone. The allograft muscle in the face showed some mix of normal muscle, which was probably the innervated muscle, versus fibrotic muscle, which probably never got the nerve fibers to start with, something that one would expect with incomplete re-innervation of the muscle. When we looked at the skin, the donor and recipient, the donor, you can see with naked eye that the epidermis is thinner than the recipient skin, so there are some chronic changes perhaps related to the transplantation. There also appears to be reversal of collagen and elastic fibers in the dermis, which requires special stains. But interestingly, the recipient skin had more neutrophilic lymphocytic infiltrate than the donor, so clearly no rejection at the time of his demise. And this is the cause of that. The liver just looks ugly, and he really wasn't a candidate for liver transplantation at his age of 70, and other comorbidities. So if I were to summarize, I think that there have been major accomplishments in the field of face transplant. We have improved the surgical technique and really defined it. And as you could see from the example of our 9 patients, right now, we really use the same operation for every single one of the patients. We just include the parts that need to be included. We still believe that being conservative is a safer way for our patients. We don't think that patients should die if the face rejects. On the other hand, you know, the conversations that French team and some other US teams have before the transplant is the opposite. They say if the face fails, you die, and patients are willing to accept it. Now that we are starting to get a sense that maybe there is a half-time of 10 years or somewhere in that vicinity, I think patients may respond differently to that question. But on the other hand, being conservative gives us, say, the backup plan B options. On the other hand, the aesthetic outcomes are definitely better if you replace more of the face with the donor tissues. And you have seen some of the, especially Ed Rodriguez, who have pushed the limits. The patients look fantastic, but they really, I don't know how he's going to solve the problems when the face starts failing. We certainly know at this point that there is a positive risk-benefit ratio at 5 years and possibly beyond. And I do personally believe that face transplant should be the standard of care for selected patients, where the alternatives are really not even comparable. We can't even compare costs because the outcomes is just night and day. And the 5-year follow-up, we could only get to the New England Journal as a correspondence, so there's a fairly sizable attachment that you would want to download digitally, because a lot of the data is there, far more than any regular paper would have. But New England Journal has their own rules how they publish things. But nonetheless, we have shown that motor function improves on the scale where on the y-axis 1 is severely impaired, 2 is moderately, and 3 is normal function. We're somewhere about 60% of the function of the normal face. And that's probably in line with what you would see after peripheral nerve repairs. You generally end up getting about 60%. The sensory function continues to improve, and it seems in some patients really gets to very, very high, near normal range. We have classified rejection episodes, and fortunately we don't see the worst ones, antibody-mediated rejections, very often. But there are a number of rejections, and again, most of them can be managed fairly conservatively. And infections tend to trail what is known in organ transplantation. So early on it's really opportunistic perioperative type of infections from the donor, nosocomial from the recipient, and so forth, colonization. Then later on it becomes more of a relapse of these, and ultimately it's more community acquired, and particularly viral infections that they tend to be a little bit more susceptible to. So we still have a lot of things that we can improve. I think the operation's got to be shorter. We gotta probably stagger the teams. We can't have everybody get excited at the beginning and get tired at the same time in the end. We can still do better in terms of patient safety and better outcomes. There's still room for improvement, in particular in hand transplant, where the outcomes are not particularly better than prosthesis, with the exception of sensation. But I have no doubt that we're really changing reconstructive to what would be more of a restorative surgery, providing our patients with human appearance and function of the face far superior to conventional reconstruction. So with that, this is the summary of all the patients that we have performed. And incredible team. Of course, I'm the one talking, but there are dozens and dozens clinicians that are helping, nurses, speech and swallow therapists, other specialists, experts on derm path, immunology, psychiatry, social work, and so forth. So with that, I would be happy to take questions. That concludes my presentation.
Wow, Bo, thank you so much. Always an incredible talk, and every time I hear the talk, there are more updates and more patients and more long-term follow-up. I really want to congratulate you on this incredible work. I think it's the amount of work, the degree of undertaking to do these operations, the planning and the cadaver dissections, and obviously the patient selection process and everything. I think it's really next level stuff compared to most things that we do in reconstructive surgery. So I really want to commend you on that.
Thank you.
I have a couple of quick questions. Early on in your talk, you mentioned about funding and about how some of the national funding basically is drying out or has dried out, and many of the agencies are saying, oh, well, we've already kind of done this proof of concept. Where do you see the field of face transplantation going in light of the funding challenges? Do you see the numbers continuing the same way? Do you think it's going to be a challenge now? What do you think?
Yeah, so we, every other year we have organized, Scott Levin and Andy Lee primarily drove it in the past years. Consensus conference with, and Andy Tsakis was actually the last one who organized it in DC. Consensus conference with the third-party payers, Medicare, and all the involved major insurance companies. And I think we're making progress. I think early in the days, they kind of looked at it and said, okay, guys, first of all, you got to work together. You got to create some degree of consensus on indications. You got to figure out how the outcomes really compare to other things, what's the cost, and so forth, basic things. And we have done a lot of work. There have been a lot of published articles on the topics. And I think the closest, frankly, is the face to get covered for a number of reasons. One, they do see that there is really no good alternative. And two, there are not as large numbers as you could imagine for amputees there would be, so they're not scared financially. And third, there have been some really compelling stories while the and outcomes, while the hand transplant have been sort of mixed bag in terms of good and bad outcomes. So face is probably getting closer, but nonetheless, even though they're starting to sympathize, and our Medicare director, for example, for the region said, I'm happy to cover your face transplants, but you guys don't have codes. So the big issue right now is how do you assign codes for the operation, for surgeons reimbursement, all these things, and that's a whole another game through American Medical Association lobbying, provisional codes, and so forth. And that's where I feel like we're gonna struggle the next couple of years. So to answer your question, I think there will be probably reduction in number of transplants for a foreseeable future for these reasons. But once we get through that, then my hope is that the patients that really should have it will be able to get it.
Got it. Well, that's good to know, because I think the cases that you've shown, there really are no good alternative options for these severe full face burns. I think we can all agree that conventional operations can be done in some of the cases that are more like partial, for example, but clearly not the cases that you've shown. So thank you for that. The other question that I have is with regards to achieving expertise in this very difficult and specialized field. So as we know, obviously you need to do many, many cases and many run-throughs, if you will, to become an expert. And each of these cases is very different from an anatomic standpoint. And as we know, there are multiple centers who either have done face transplants or are planning on developing VCA programs. In your opinion, and obviously there's a kind of this is more of a conjecture type question, but how many centers do you think a country like the US would need to make sure that not only are patients able to be serviced by a group that is somewhat close to them, but also still maintain the volume for these teams to become experts in it?
That's a great question. It actually came up during the discussion on the consensus conference as well. The insurance guys, Anthem, Blue Cross, those big players, they anticipate probably only 3-4 centers of excellence, and they will not really be looking for the reasons you have mentioned, for the expertise, for the necessary kind of concentration of expertise in low volume. That's what it's going to start as. So I could imagine geography will play a major role, but there's just no reason to have, you know, one at Brigham and one at Mass General, which is currently what's happening, or, you know, in one town or city. And we're trying to resolve those things and make sure that it kind of coalesces into one program. But, you know, there are a lot of people that are ambitious that know that they can do the surgery, which I have no doubt they can. There are many talented surgeons, but probably doesn't make sense to go beyond those 3-4 centers.
Yeah, that makes sense, and that was kind of my intuitive guess as well. Obviously, you know, our field is very different than this, but even in the field of replantation, for example, we don't feel we need that many centers just because we need the volume to become experts in it. So thank you so much for that. We have the privilege of having a number of surgeons from around the world, including many colleagues from India on this call, including Dr. Venkatramani from Ganga Hospital. And he, first of all, says hello. Second, the question was raised that, you know, these full face burns are not uncommon in the developing world, and especially in India with acid burns. And the question is, are there special considerations from an immunologic standpoint that you have to pay to burn patients, even if it's kind of a long-standing issue and many years later?
Yeah. Definitely there are, and I think the key is really to treat the patients at the time of injury slightly differently than the standard would be. If it is isolated acid burn to the face, like a lot of the cases that I've seen from India or Middle East, fortunately those patients don't have the systemic inflammatory response. They don't need extensive blood transfusions, and they're not exposed as too many sensitizing events as large burn patients, large total body surface area burns. So those probably have the best chance of being reasonable candidates with relatively few immunological barriers. But the key, I would say, is limit any blood product sort of exposure and not use human cadaver skin or human allografts for skin coverage or temporary coverage, as many surgeons do, because all of those are sensitizing, and rather resort to either synthetic dressings or autografting early on. But those patients under those circumstances would be about the same as gunshot wound to the face or, I don't know, animal attack to the face. Once you get the total body surface area to 50–60%, where the patients receive massive amounts of transfusions and blood products, massive amounts of exposure to even the environment is sensitizing during the dressing changes and reoperations, then those are the cases that get really immunologically challenging.
Yeah, that makes sense. Thank you for that. And kind of a question about geography and the specifics of UNOS. Obviously, if a center like yours, which is in the northeast of the US, but also close to Canada, for example, are there, from a logistical standpoint, considerations with regards to if a patient is identified in Canada, for example, and wants a face transplant, but there are no programs available there? How does UNOS work with regards to patients from overseas who may or may not need transplantations? Is that possible? Because I seem to recall Scott Levin discussing a patient from France who Laurent Lantieri brought over to the US.
So we can, and especially when we had the funds for transplant, we could transplant from patient from anywhere in the world. The tricky part is either they would move to the US and wait for unpredictable amount of time to get the transplant, or they would have to have a direct flight to get to the US, and that kind of limited this sort of span where we could potentially get in time patients to the US. And finally, there really is a need to have specialized transplant care at the country of origin. So ultimately, these patients are expected to go home. So we had patients from Africa that would have been great candidates, but there's just no infrastructure in Africa. Their visa situation was unstable, so they ended up not getting transplanted. But same thing with South America. Some of the countries didn't have really robust programs in Colombia, Venezuela. So we ended up not enrolling these patients. But if you have somebody like Scott had from France or somebody from Germany, absolutely, those are doable things.
And that makes sense because from what you've shown, the operation, while extremely challenging, is only a part of the success of these cases. The close monitoring and all that stuff is just as important. So thank you for that.
Expertise goes way far beyond what we can offer.
Yeah. I would like to call on Dr. Greg Buncke. I know you're on the line. Greg, I was going to call on you for a comment about Bo's fantastic talk, if you're there.
Hi, Bo. This is Greg Buncke. Thank you so much. This is it's a
Hello.
tour de force. Is a real tour de force, and we've been following your work for years. And I've got to say, it's not easy continuing on with this. Questions I have to do with tolerance, and in solid organ transplantation, some of these patients develop some tolerance. Have you seen that happen, or is the skin and is just so hypersensitive immunologically that patients don't develop that? We hear about all the trouble patients, but are some of the patients actually doing better than expected?
So the quick answer would be there is no tolerance. But we have had patients that for 2 years had no rejection whatsoever, and unfortunately he started to believe that it's something about his diet and all kinds of funky things. So he started sporadically skipping immune suppression and developed really bad rejection that we were able to get under control. But ever since, he has got to the rhythm of once a year type of rejection. So there are definitely patients that do better, and we have few that have not had rejections in years. But it's probably not realistic that we would see some sort of a tolerance unless one of those protocols is developed eventually and allows us to do it from the beginning, whether it's mixed chimerism or some sort of a new drug that would allow us to manage it differently.
And nerve growth, have you, there's some anecdotal evidence that nerves actually do better in these transplants patients. Have you found that, or is it no different?
In face, the distances are relatively short, and it kind of seems to correlate to what you would expect. In hands, there is maybe a little bit of enhanced growth, but it's not night and day. It may speed up by a few weeks, maybe a month, not more than that.
Great. Thank you so much.
Oh, my pleasure. Thank you.
Thanks for that, Greg. Well, Bo, I wanted to thank you again for a phenomenal talk as always. It's always great to see you. Hopefully next time it'll be in person once all this stuff dies down. And again, thank you for all the work that you do. Your patients are very lucky to have you. It's been a pleasure having you.
Thank you very much, Babak.
And sorry, go ahead. Go ahead, please.
I just wanted to thank you. This was a tremendous opportunity. I really appreciate the invitation, and yeah, indeed, looking forward to seeing you in person again.
Great, thank you. And just a quick housekeeping item for our viewers. We continue the series tomorrow with 2 fantastic talks by Dr. David Chang tomorrow morning at 7 a.m. Pacific time, discussing a combined approach to lymphatic surgery. And then Dr. David Chuang from Taiwan at 5 p.m. Pacific time, discussing management of complex injuries of the upper limb, both former Buncke lecturers at ASRM. So we look forward to seeing you at that time. Bo, thanks again. Have a great day, and please say hello to all of our friends in the Harvard system.
Will do. Thank you very much.
Thanks. Take care. Have a nice day.
You too.